Hey there, 675. So this week we are beginning our discussion around intensive addictions treatment. Now, we had previously discussed assessment of individuals with addictions or really just on the spectrum of addiction, so that could include people who are just using substances or risky use, but obviously we know that people who score in the higher ranges are individuals we want to look at for diagnosis. And so for individuals that there is evidence after assessing them, doing the brief interview, that there could be a substance use disorder, this is when we want to begin to look into professional treatment options. So here is a little quote from the National Institute of Drug Abuse, that addiction treatment is intended to help addicted individuals stop compulsive and drug-seeking use. Treatment can occur in a variety of settings, take many different forms, and last for different lengths of time. Something that was mentioned in your Veach text was about how treatment used to consistently be 28 days. And we started to question in the last decade or so, why 28 days? Is there any evidence for that? So instead of putting people in treatment for a standard 28 days, it tends to now be tailored to that individual's needs, which is appropriate. Addiction treatment can include a wide variety of therapies, but common ones that we tend to see include behavioral therapies, which can include individual and group sessions. A note that group work has been found to be particularly effective in this population. It can also include medications, which we'll discuss, and just generally medical treatment and care for things like severe withdrawal symptoms, and if they need medical stabilization, as well as several medications, which we'll go over later, and often a combination of these. And so something I just wanted to talk about a bit when we're talking about intensive treatment for addictions is looking at how it really is an integrated type of care to meet addicts' needs, healthcare needs, because we know that it is a actual illness. We know that there is a type of brain disease that's going on in terms of the brain has been rewired to seek out the addictive substance. And we know that there are also a lot of emotional things going on. It depends on whether or not the person has healthy supports out in their daily life. There are just a vast array of factors that can impact someone's ability to get clean and stay clean. So this is why it's important to take note of the Minnesota model. So we definitely talked about the Minnesota model and how it is a prevailing model that is used in inpatient care. And have there been issues with the Minnesota model over time? Yes, but it really was the blueprint for the modern understanding of a multidimensional or multidisciplinary approach to addictions treatment. And I think that's actually really cool. Addictions treatment is one of the first places that we saw this concept of integrated care, because the issue in itself is so complex, and that it is biological, it is emotional, psychosocial, it is a social issue as well. So let us just take a little look. This is a graphic that is in your text. These are components of comprehensive drug abuse treatment. And just look at this chart. And I just want to ask, what types of providers could be involved here? So if we look a little closer, we see things on the inside are sort of those main treatment modalities that are going to be needed for that individual to find stabilization and to find sobriety. So that includes a treatment plan, which involves a counselor, right? A substance use counselor, behavioral therapy and counseling, substance use monitoring, self-help and peer support groups, pharmacotherapy, clinical and case management. So we have case managers that could be involved here. There are hopefully medical professionals involved in subscribing the pharmacotherapy. But if we also look on the outside, family services, childcare services, vocational services, continued mental health services, say that individual has a dual diagnosis, which we know is extremely common. Other medical services, educational services, HIV/AIDS screening and services, legal, financial, and housing transportation services. So competent addiction treatment can involve such a wide range of health professionals, and not just health professionals, but again, people who might provide more functional services, such as caseworkers, social workers, etc. So this is pretty amazing to me that, again, addictions was one of the first places that we realized that people can have increased chance of meeting their treatment goals and finding wellness when they have wraparound care, because addiction impacts the family, it impacts people's ability to work, to maintain employment, and therefore getting a paycheck so that they can have things like housing. And so when individuals are really struggling with addiction, often the family might need additional support. That individual might need additional support, might need vocational services. How do we then train them so they can go and keep consistent work, so that they have the support systems in place that they need to take care of themselves, to also go and continue to receive services by going to things like AA after they're out of intensive treatment, etc. So we, of course, are the individuals who are kind of more in the middle, actively involved in the actual treatment of the addiction. So that is one reason why I also wanted you to read Connor's chapter 4 this week, which is all about treatment planning. So let's say we've had a client, again, we've gone through the SBIRT process, we've assessed them using the DAST and the audit, we've given them a diagnosis, and let's say this individual has severe alcohol use disorder. We want to then, if we're the treatment providers, provide a treatment plan. And so a treatment plan is really a little kind of record of ways that we are going to create little meaningful goals that will allow the individual to work towards sobriety and holistic wellness. So what are the goals of a treatment plan? To return to productive functioning. We want this individual to be able to be back in their family systems if they're appropriate to be around, back in the workplace, back in the community. We want them to maintain sobriety. We also want to find ways to reduce their chances and triggers for relapse. Relapse prevention is a huge part of addictions treatment, but we're going to talk about that more next week. But again, treatment goals are something that you come up with the client. The professionals should be doing with the client in tandem, because if the client is not motivated, if the client doesn't feel like the treatment goals are a fit for them, they're not likely to follow through. So we want to increase their chances of success by doing this as collaboratively as possible. And so here are some guidelines according to Connors for well-formed treatment goals. As I said, salient and meaningful to the client. They should be incremental and thus more manageable. Concrete, specific, behavioral focused. And so just breaking down those pieces, they need to be small steps towards success. We understand that addiction is incredibly complicated and difficult to overcome, so you want there to be small, reasonable steps for them to work towards sobriety, which, kind of fits in line with the concept of when we do SBIRT. Sometimes we're really just getting people to reduce their use a bit. Maybe they're not ready to completely let go. For some individuals, they might be in a medical state where they need to completely go cold turkey. But that same concept applies if we just want people to find success where they're ready to find success. Focused on increasing desired behaviors. It should include progressive steps towards achieving goals, be realistic and achievable. It should be perceived as requiring work and effort, which is again why we need the client's buy-in to this process, because they're going to have to be the ones going through this process. And it should be appropriate for the projected treatment period. So, once again, if a client comes in, if your goals for them as the treatment provider are you are going to be entirely sober from alcohol, you're going to cut off all old contacts with friends that used to drink with you, and you're going to go to job training. If that client is still in the contemplation stage of change, which means that they have some motivation towards change, but they still have some reservations, right? They're not going to be able to accomplish all that. And again, what if you're just seeing them for a month? That is not enough time to support them in making those changes. So it needs to match where the client is, it needs to match their treatment period, and they need to be achievable, small step goals, keeping in mind that because of the actual health concerns, as far as health concerns come in, that might require kind of larger goals in terms of reducing substance use itself. But there's so many other pieces when you're getting well from addiction that need to be looked at. Here's an example of a treatment plan. This can be a common type of document that counselors and other substance use providers fill out with clients, and notice it can have the client, the problem statement in terms of what is the issue that needs to be addressed. It might list the goals. So say the goal is to, quit drinking alcohol, then you might include objectives. So what is that specifically going to look like? So for this client, it means will not go out to the bar, will avoid seeing that set of friends that I tend to drink with, will check in with my sponsor to ensure that I am making the choices to stay sober. Interventions, what can the counselor and staff do to assist the client under what circumstances? So that might include client will attend group therapy 3 times a week, individual therapy once a week, might do blood tests or urine analysis for alcohol. I don't really think actually alcohol. Does alcohol show up in urine? I don't know. I can't remember. Other drugs do. Participation in treatment planning process. So to what extent did the client participate in this treatment planning? And who else could be involved? So this might involve other family members and friends who are concerned about this individual, or perhaps a medical professional that has been involved in this individual's care. Say they're coming from the ER because they had a severe episode due to alcohol, and they're coming in with strong medical recommendations. It'll be signed by the client and the counselor, etc. The other thing to note is I said that where the client is in stages of change can really impact this process. And so something they talk about in Connors is, getting them to a higher stage of change does not preclude doing the intervention plan, but it might mean that you want to use those motivational interviewing skills, you want to use change talk, you want to use different skills to motivate them to continue through the stages of change. So help them find more buy-in in this process. But again, you want to do it collaboratively. We cannot force people to get better. So another important topic, an important tool for understanding how do we decide what type of treatment someone needs. We know they might have a use disorder of some kind, but what is the right treatment to match to that need? Luckily, we have ASAM criteria, and this is a almost nationally used system. It's required in over 30 states, including Kentucky and Ohio. So what is this? So ASAM is the American Society of Addiction Medicine. And it created criteria. It had a quest to design a national set of placement criteria providing outcome-oriented and results-based care in the treatment of addiction, and they started this in the 1980s. It is the most widely used and comprehensive guideline for placement, continued stay, and transfer discharge of patients with addiction and co-occurring conditions. And placement is determined on scores along 6 dimensions, and this includes criteria for both adult and adolescents. I have used ASAM criteria out in my work in the community. If you are working in mental health, it is likely that you will need to be trained in how to use ASAM criteria since it is nationally used, and again, it's used in Kentucky and Ohio. So let's look at this. ASAM, again, it has 6 different dimensions. Notice, so the first dimension is related to their intoxication or withdrawal potential. And so that speaks to the level of the impact of the substance on the individual in terms of are they experiencing withdrawal, tolerance, intoxication systems. So you want to explore an individual's past and current experiences of substance use and withdrawal. And I apologize that this does appear for some reason a little bit fuzzy. Dimension 2, biomedical conditions and complications. What is their health history? What is their current physical condition? And some of that could include withdrawal symptoms, but we specifically want to look here at other types of physical conditions that could be impacting this. So for someone with alcohol, for example, they might have liver issues. That could have been caused and was likely caused by long-term alcohol use, since alcohol really does impact the liver, but it's still a separate thing that we want to keep in mind. But let's say the individual has diabetes, or a more serious chronic health condition that you would want to keep in mind as you're deciding what type of treatment they might need for their addiction, because we want to, if they have serious physical complications, we want to be sure that they're receiving addictions treatment in a place where we can also attend to those physical health issues if needed. Dimension 3, emotional, behavioral, or cognitive conditions and complications. So this can include assessing for pre-existing mental health conditions, as well as just generally their thoughts, emotions, and mental health issues. How emotional are they? What are their coping skills? What tend to be their thought patterns? Are they very negative thought patterns, for example? Is the individual very critical of themselves? Do they have depressive symptoms, anxiety symptoms, etc.? Those are things you want to take into account. Dimension 4, readiness to change. So we're very familiar with that concept by now in terms of where do they fall in terms of the stages of change and how ready are they to progress to a higher stage of change. Dimension 5, relapse, continued use, or continued problem potential. This is where you would explore how has this individual tried to get sober before? If they have, how did that go? Likely if they're there with you for screening for addiction, they have likely experienced relapse. So how many times have they tried to get clean? How many times have they relapsed? How many times have they tried to get clean and just not been successful? And what were some of the problems that kept them from being as successful as they wanted? So those things take into account. And then dimension 6, their recovery or living environment. Are they living with people that are supportive of them maintaining sobriety? Are they socially connected with people that want them to maintain sobriety? Or are they connected with individuals that are enabling them or are users themselves? Are they going to places? Are they engaging activities where they are more likely to be tempted for use? Items are scored, of course, along a spectrum of mild, moderate, and severe, and these total scores indicate the level of needed care. So they will get a score for each of the 6 criteria, each of the 6 dimensions, and then that total score will indicate what level of treatment they need. Notice that this is also a spectrum approach of understanding that some individuals have more mild addiction issues and some may have more severe issues and require more stringent and organized care. So another thing to note, though, is that let's say an individual comes in and they're really scoring at a moderate or severe range. If they don't have the ability, if they don't have insurance that will pay, for example, for more intensive inpatient care, it is likely that they could be bumped down to a lower level of care because that's what their insurance will cover, that's what they can afford, and so sometimes providers are forced to make choices to get them the best care that that individual can get according to reimbursement guidelines. So that kind of sucks, but it's a reality of the system. Also client willingness, because if a client is completely unwilling to go to treatment, it can be quite difficult to get them to do so. There are, of course, cases where they can be admitted to care against their will, but that tends to be in very severe circumstances, and it can be difficult to force someone to stay. And so what I also wanted to look at, this would tended to be a class discussion before this class was forced online. What would SBIRT already tell us if we had completed that process with the client? I guess I just want you to see that there are similarities around different methods of assessing clients, because obviously there are different dimensions that we need to understand when assessing someone for substance use, and those are consistent regardless of the approach that you're taking. So we would already know definitely about the readiness to change. We would probably have a sense of their attempts to use or quit use, that around dimension 5. We might have a sense of dimension 6. We might have a sense of dimension 3. We're probably less likely to ask questions about biomedical conditions and complications. We might know some about how we'd want to ask about current withdrawal, or experience of tolerance, etc. ORs and other MI techniques are recommended when getting this information. With a client, now often you're just going to be, when I was using ASAM, it was kind of a computer system and I just clicked the box, but that was after having a clinical interview. So you want to be sure that you're getting a lot of information from clients, but making sure you're doing it in a respectful and clinically effective manner. So that's why we use things like open-ended questions, affirmations, reflections, and summaries, because they tend to be very respectful of the client. When done well, they can be very collaborative. They invite the client to tell their story, and we want them to tell their story. We want them to be open with us and give us a rich picture of who they are and where they are so that we can adequately and accurately assess them on these different dimensions. So let's look at the different levels of care. When I talk about, at the end, they would get a score according to ASAM criteria. This is what each of those scores would indicate. So if they get a score of 0, they don't need treatment, right? But we go to point 5, which is early intervention, and that could look something like the brief negotiated interview. But level 1 includes outpatient services. And this may be, this can sort of be lower key, maybe not a lot of weekly meetings per se, but as we move up, we go to more intensive care, more consistent meetings. In level 2, we're still doing outpatient, but it's more intensive, so that can involve the client going to treatment maybe 3 or 4 times a week. Maybe they're going to a group 3 times a week and individual counseling once a week, up to partial hospitalization, which is where an individual might go and spend much of their day in hospitalization. 2.1, intensive outpatient, moving up partial hospitalization. And then 3 is where we get to residential or inpatient services. So what we would think of traditionally as rehab. And notice there are also different levels in there. Is it clinically managed, low intensity? Is it population specific, high intensity? Clinically managed, high intensity residential services to medically monitored. And so that would be level 3.7 with individuals that might have severe physical issues or severe withdrawal symptoms, up to level 4 where they full-time are in medically managed intensive inpatient services. These would be individuals who are just physically so unwell that medical monitoring and stabilization has to be the first step before engaging in other types of treatment. And so here is again another description of those levels of care and what they could look like. And notice if you just go through, it goes up in time from, assessment and education to less than 9 hours of service to 9 hours or more, to 2.5, 20 hours or more of service, to rehab 24-hour structure with available personnel, to 3.3, 24-hour care with trained counselors to stabilize multidimensional imminent danger. So we notice that as sort of the severity of the addiction goes up, as well as the severity of the health concerns, that is going to lead to a higher level of care. Just letting you read through that. And so level 4 would be the most intensive, is 24-hour nursing care and daily physician care. Again, this is an individual that is experiencing extreme physical symptoms. They might have unstable problems in dimensions 1, 2, or 3, and the counseling could be available, etc. And also note that people in opioid treatment, we have come to include that it's likely that they will need opioid agonist medication and counseling to maintain sobriety. We've shown that medicated treatment is especially effective for individuals with opioid addiction. So breaking that down, we're really starting this discussion of what is the difference between inpatient versus outpatient care. And so we can understand that there can be a level in severity and intensity, the length of stay, etc. But generally, residential care, which is level 3, is going to take place in hospitals or specialized residential treatment facilities. The patient is going to stay full-time. It is going to generally be 28 days to 6 months, and that can vary. And of course, the insurance coverage can really impact how long that stay is. It is extremely disruptive to daily life. Individuals in inpatient residential care are not able to go to work. They're not able to see their, regular friends and family, involved regular activities. They are spending full time every day in that facility. Of course, that comes with increased monitoring and professional support, and it is generally a lot more expensive. And so this is where I take a pause and I include a video. It is the first one listed. This is a young man talking about his experience in an inpatient facility, and I think it is just incredibly effective at giving us a picture of what that's like. And he specifically talks about what is it like to go into a residential facility and to find sobriety and to have all the supports? And then what happens when you leave? And then suddenly you are tasked with maintaining the sobriety on your own. So there's an incredible amount of support and structure in residential treatment, which can be very useful in helping individuals who struggle to give up substances finally quit and find sobriety. But then again, it can be a huge change when they're then out of those services. So then we have outpatient services. And so this is level 2. These are services that generally take place in community mental health clinics or hospital outpatient programs. This is where the patient might stay part of the day, several times a week, or just come in for, 2 or 3 hours through the week, depending on if there's partial hospitalization or not. This is usually a bit longer, so this is be 3 months to over a year. It is less disruptive to daily life. Individuals are usually still able to do things like go to work, be out, in the community, be able to go to their homes at night. But it is more effective when they have stronger social support at home. So if they're going back home to other individuals who are using or enabling or encouraging them to use, that can be less effective, obviously, than people who are supportive of their sobriety. There is consistent monitoring in outpatient care, but not the same as the constant monitoring in residential, but still there's that kind of consistent check-in. And so this can be a better option for individuals with a milder addiction, and it is often more affordable. So that next, I'd like you to watch this video with this man talking about his experiences in outpatient care. So in intensive, inpatient, as well as outpatient treatment, individuals really should still be receiving evidence-based counseling modalities. But one thing that you should always take into account as a care provider is, does this individual possibly need medical treatment, and/or have there been biological impacts from their substance use? We know that long-term use of a lot of substances can result in impairment in the brain. We know that addiction self is sort of a type of impairment of the brain because it impacts how people learn, and then they start to crave a substance that's actually not healthy for them. But we know that different substances can impact other areas of the brain, so that's something you want to keep in mind. So it is a really good idea to refer people, particularly with long-term substance use issues, to medical providers to be assessed for how has this actually impacted the structure and function of their brain. And so that can, involve mild issues, but particularly for issues with long-term alcohol use, for example, we know that there can be pretty significant brain damage. So we want to understand how they are functioning neurologically, because that could impact the type of treatments that we use. For example, cognitive behavioral therapy is commonly used in addiction treatment, but it can be particularly difficult to work with someone around pinpointing their thoughts and their reactions and taking note of their behaviors if they have experienced brain damage that inhibits their ability to do that as effectively. So that's why we want to always make sure we're paying attention to their neurological health and referring them to a medical provider. We also want to look at, do they need detox? And so that would be, are their withdrawal symptoms dangerous, difficult to manage? Do they need medical help to stabilize before they can even begin the process of going into treatment to work on sort of the more behavioral elements of addiction treatment? Do they need medicated assisted treatments? We know that that is particularly useful with things like opioid use disorder, but we also have these available for things like alcohol use disorder and for individuals who obviously are using tobacco, although individuals with tobacco don't tend to show up in intensive outpatient or inpatient care. That tends to be something that they manage on their own or at a lower level. We also want to remember, of course, that co-occurring disorders are the expectation, not the exception. So we want to make sure that we're assessing clients for other types of mental health disorders. And of course, as I said earlier, it's important that we're using evidence-based counseling modalities. Very common ones beyond CBT include motivational interviewing, and it in itself is not a theory, but it is a strategy of techniques that we've found to be extremely effective with this population, again, and contingency management, which we talked about when discussing family therapy. That is the concept of, for clients tend to be rewarded when they are able to maintain sobriety, when they are regularly attending treatment, and that reward could look like vouchers, it could look like access to vocational training, whereas if that individual were to, slip, have a relapse, or stop attending treatment, then there could be consequences. So that's a very behavioral approach. Also the 12-step facilitation model, which we'll talk about a little bit in a moment. So addictions treatment medications, there are obviously different options. We have already discussed these, but they're important to know and remember. Wink, wink. For opioid dependence, methadone, buprenorphine, and now Trexone. We also have medications utilized to treat for alcohol dependence. Medications for alcohol dependence, so disulfiram. I don't know if that's said correctly, but that drug actually helps by causing feelings of illness when someone with an alcohol use disorder goes and drinks. So because it can make you sick when you drink, there can be a conditioning to then not want to drink anymore. Acamprosate and naltrexone, which notice naltrexone is also used for opioid dependence. Both of those are thought to help reduce cravings for alcohol, and then hopefully supporting sobriety in that way. And then medications used to treat with dependence and withdrawal from tobacco can include, of course, nicotine preparations, gums, patches, nasal sprays, etc. Varenicline and bupropion, which are both thought to help reduce cravings for tobacco and also reduce sort of the pleasurable benefits, reduce some of that dopamine release that would happen when going back to smoking. And again, what are some of those evidence-based treatment modalities? CBT. So CBT is all about paying attention to what are the patterns in our thoughts and understanding that what we think, the self-talk that we have, the different schema that we have, impacts how we feel and act. So also looking at behaviors, looking at what we're doing and understanding that what we do affects how we think and feel, and of course our emotions, which is how we feel can also affect how we think and act. So really wanting to explore these different areas with clients and help them be mindful of them so that they can make different choices. It's based on the concept that bad learning leads to bad behaviors. So how do we put in more learning, successful learning, so that they can have successful behaviors? And so in this approach, which is considered the most widely used evidence-based theory, part of that is because it's the easiest to study, but individuals learn to identify and correct problematic behaviors by learning various coping skills and self-monitoring techniques. The 12-step facilitation model. And I think Veach does a nice job of talking about this model in here. But if you want to learn more, I actually link in this I would plop this up in class, but this is actually linked to the publication for Project Match that they discuss if you want to go through that. And so the 12-step facilitation model, really break it down, it is actually individual counseling sessions, but it follows a lot of the same tenets as 12-step programs like AA. And so I actually have this linked here. This is your last video to watch. So if you want to pause at some point soon and go through, and it will go through the 12 steps. So what are those 12 steps? And in the book, they really break down what are different treatment options at each of the steps. And so again, according to the National Institute on Drug Abuse, there are 3 key concepts. The first is acceptance, which includes helping clients realize that a drug addiction is a chronic progressive disease over which one has no control. That life has become unmanageable because of the drugs, and that willpower alone is not sufficient to overcome the problem, and that abstinence is the only alternative. One thing I will note about the 12-step model, it has been effective, but it does tend to have it's an intense approach. It's all or nothing. It's very aggressive, but people need that when they're dealing with an addiction often. Second concept is surrender, which involves giving oneself over to a higher power, accepting the fellowship and support structure of other recovering addicted individuals, and following the recovery activities laid out by the 12-step program. So again, the 12-step facilitation model is really setting people up to stay involved in a 12-step recovery program after they have finished sort of intensive inpatient or outpatient treatment, etc., active involvement in 12-step meetings, related activities as the last concept. And there has been a lot of success with this model, because we do know that, again, the 12-step programs are widely available for individuals once they finish, inpatient or outpatient treatment. Mutual support can be really important, and having a sense of community and having support from other individuals have worked through an addiction. So even there can be a lot of criticism for the 12-step model, it does tend to be effective because, again, it has services everywhere and it provides consistent support and structure, which is what a lot of individuals overcoming addictions really need, is that structure and support. And of course, what are some of those critiques that tend to be really common? The focus on a higher power can look really different at different locations, and several of you, may have been able to go to some 12-step meetings and see that there can be a sort of religious focus, but for some groups that can be more general and spiritual, and some other meetings might run it in a way that it's a little bit more tied to specifically a Christian tradition. So atheists have had a hard time getting engaged in 12-step programs at times, but the concept is really meant to be that there's like a higher power, which means that something beyond yourself matters. And that can be, a useful thought for a lot of people. So that's the 12-step facilitation model. Again, if you want to really get into the details of Project Match, make sure that you download this PowerPoint, which is in course files, and click here. And so to wrap this up, discussion board. So, in looking through these chapters and doing your reading, after you finish and you've read the lecture or watched this lecture, I'd like you to go and look at the case of Paul on page 108 in the Connors text, and kind of answer these questions. Is there other info that you would want to know to assess him with the ASAM criteria? So is there something missing in the Connors that would show up in ASAM? Either, emotional behavioral, readiness change, relapse continued use, recovery living environment, etc. What placement level do you think would be a match for him based on the severity of his issues? Again, I know that you're not actually rating him with ASAM criteria, but if you were to take a stab at that. And is there a benefit in utilizing a more interdisciplinary approach involving other types of health professionals compared to the treatment plan put together in the text? I just want you to make an attempt at that, and we'll see how it goes. So that is your discussion. Do this activity, answer these questions. I look forward to reading it. And of course, again, if you have any questions about the material as you're reading through or looking at the lecture, don't hesitate to reach out. Hope you guys are well. Bye, you guys.